Hello and welcome to the first HEAL Headliners webinar. My name is Carol Giannessi, and I will be assisting with the logistical support for this Zoom session. To provide comments or questions, please open the Q&A, which is located towards the bottom part of your screen. If you need technical assistance, please type the issue into the Q&A, and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking on the CC icon at the bottom of your screen. I will now turn it over to Dr. Walter Koroshetz, the Director of the National Institute of Neurological Disorders and Stroke.
Hello, can you hear me okay? Great. Well, it's a great pleasure to be involved in this panel. It's something dear to my heart, is understanding how to take care of emergencies as they present to emergency departments around the country. It's in our country, it's the place where no one gets turned off. Everybody's accepted, and docs there, really put their life on the line to do the right thing. And in this space that we're talking about, the management of pain and the management of opioid use disorder. The emergency room is just an incredible point of convergence. And so really interested to hear from our investigators today who are part of the programs run by the HEAL Initiative. And if I could have some slides, I could talk to you a little bit about the HEAL Initiative. It was started probably about 5 years ago now, and it was in response to the opioid epidemic, which has continued to kill hundreds of thousands of Americans. It's just a tragic tragedy in our country. And the thought was that NIH could really help by funding research that would decrease the deaths due to opioid overuse, prevent opioid overuse disorder, and also try and develop better treatments for pain, because at the beginning it was treatments for pain with opioids that led to the beginnings of this opioid crisis. Since then, of course, it's been taken over by the drug dealers who are putting fentanyl into just about everything you can imagine. Incredibly toxic drug. The problems continue. We made some progress in terms of the use of prescription opioids has dropped in this country 30–40% in the last 6 or 7 years. But of course, the deaths due to overdose have not. We are also faced in this country with widespread disparities and health inequities. And HEAL certainly is right in the midst of that with the opioid crisis and the treatment of pain. There are biases that we know about that affect how certain racial ethnic groups in our country are treated for their pain. And there's certainly cultural factors that are, and socioeconomic and social determinants of health that are driving a lot of the opioid crisis. So HEAL is doing research in these areas to see if we come up with some solutions that can help solve some of these problems. On the pain side of the HEAL Initiative, we have programs that are developing new therapies for pain, and we have programs that are basically doing kind of comparative effectiveness research, learning what is the best treatment for different types of pain conditions. And in the opioid overuse space, we have a whole suite of programs that that range from trying to go into whole communities called healing community studies, working with everybody who can possibly engage to reduce opioid overuse in those communities, all the way back to developing actual medications that can reduce cravings and help people who wish to get off their opioids. So it's an amazing program. The HEAL Initiative It is also, besides the actual research, it's building a research workforce that we didn't have before, that particularly in the pain area, that will also have impact in and of itself going forward. So really exciting program that's been going on. It's, it's run out of the NIH, but we don't actually do the work. The work is done by the folks you're going to hear about, particularly the folks in the emergency departments. And so, and have to, hats off to the coordinators, the investigators, and the patients who take part in these studies. Those are the people who really deserve the credit. So with that, I'd like to turn over to our first speaker. And I do not have my agenda up with me right away. Let's see. See. Do not have it. Let's see.
Hi, it's
Monica, yes. All right, so Monica is the endowed chair for women in science and medicine, associate dean for academic affairs at Children's National Hospital. She's a tenured associate professor of pediatrics and emergency medicine at George Washington, and leads an NIH funded research program called ADAPT, which is addressing disparities through advocacy, prevention, and technology. And her work focuses on identifying and addressing inequalities in healthcare to achieve health equity for children. And the title of her HEAL project, the title of her talk is Project Addressing Inequities in the Emergency Department, called PAIN. Monica?
Thank you. I'm just going to share my screen. So good afternoon, everyone. I'd like to first start by thanking the NIH HEAL Initiative for helping to fund our efforts to eradicate inequities in how we manage pain for children in the emergency department. I have no disclosures. So disparities in healthcare have been well documented and have received considerable attention over the recent years. In 2002, the Institutes of Medicine, now renamed the National Academy of Medicine, released a report which documented significant variation in the delivery of healthcare by race and ethnicity, even after we adjust for insurance status, income, age, and severity of conditions. And in this report, they noted racial and ethnic differences in the management of a wide range of conditions, even those that are as well studied as cardiovascular care and cancer treatment. So when we talk about disparities, it's important for us all to have a shared understanding of its definition. The NIH defines health disparities as differences in the incidence, prevalence, mortality, and burden of diseases and other healthcare conditions, or I'm sorry, and other adverse health conditions that exist among specific population groups in the US. What I'd like to focus this talk on is the concept of healthcare disparities, which are defined as racial or ethnic differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, and appropriateness of intervention. And so in this report, the National Academy of Medicine specifically addressed healthcare disparities, again, meaning disparities in the quality of healthcare. And this is a schematic that describes their definition, which I had previously introduced. So we can see healthcare quality along the y-axis, and we see that quality of healthcare is lower in minoritized populations compared to non-minoritized populations. And that difference is ascribed to clinical appropriateness and need, as well as patient preference, healthcare systems and the legal and regulatory climate, and discrimination stemming from biases and stereotyping. And then it's the latter two that contribute to racial and ethnic disparities that we see in healthcare. So in that report by the National Academy of Medicine, only 5 of the 103 studies that they cited included evaluation of care that's received by children. And so is this because children weren't represented, or is it because children actually aren't subjected to disparities? Well, the American Academy of Pediatrics decided to conduct a review of the literature to answer that question. And in their review, they found over 100 studies addressing racial disparities in child health. So in response to the paucity of pediatric representation in that National Academy of Medicine report, the AAP published their review and concluded that racial and ethnic disparities in children's health and health care are quite extensive, pervasive, and persistent. So as we go through this talk, it's incredibly important to remember that race is a social construct. And when we're measuring racial and ethnic differences in care, we aren't measuring some sort of biologic difference. Rather, we're measuring the impact of racism on societal resources, such as healthcare access and delivery. So why do I study racial and ethnic inequities in the emergency department? Remember that the emergency department is a major source of healthcare provision for children. Over 30 million emergency department visits are made by children annually. And as was stated earlier, the emergency department provides a universally available source of healthcare access, right? We do not turn anyone away because of their insurance status, their race, their ethnicity, their language, or socioeconomic status. So to get more details into this talk and into the project that we've been funded on, I'd like to spend a little bit of time talking about appendicitis. So analgesic use is one of the mainstays of managing children with appendicitis. And we conducted a national study to identify whether there were any racial or ethnic differences in analgesia use when children were diagnosed with appendicitis in the emergency department. So over the 10-year study period, we identified 1.2 million emergency department visits with diagnosed appendicitis. And in that population, a little over only 50% of children diagnosed with appendicitis received any type of analgesic medication. So that includes even just one dose of acetaminophen or ibuprofen. And only a little over a third received opioids. So in this study, we found that there were no racial differences in the overall use of analgesia between Black and white children, meaning that we were just equally bad at providing pain medication to all children. But when we did use analgesia, we were more likely to treat pain in white children with opioids and treat pain in Black children with non-opioids, like medications such as acetaminophen or ibuprofen. So then we decided to stratify our analysis by pain score. And after adjusting for ethnicity and triage level, we found that among children with moderate pain, we were less likely to treat Black children with any analgesia. In children with severe pain, we were less likely to treat Black children with opioids. So in other words, in children with moderate pain, race contributed to whether or not a child received any pain medication at all. And then in children with severe pain, we were more likely to use medications like morphine and Dilaudid for our white patients, and medications like ibuprofen and acetaminophen for our Black patients. And so this indicates that there seems to be a threshold effect in the use of pain medications overall and in the use of opioids, and that threshold differs by race. We also conducted a multi-center study of more than 7,000 children who were diagnosed with appendicitis and looked at rates of appendiceal perforation. So what we found was that in comparison to non-Hispanic white children, non-Hispanic Black children had higher likelihood of appendicitis perforation. And because we know that delayed diagnoses can lead to perforation, we then looked at what proportion of these children had a delayed diagnosis. And we defined a delayed diagnosis as one in which a child had had a previous emergency department visit within 7 days of that appendicitis diagnosis. And in comparison to non-Hispanic whites, non-Hispanic Black children were more likely to have a delayed diagnosis. So then we looked at whether or not children who had those delayed diagnoses had definitive imaging during that initial emergency department visit. And what we found was that non-Hispanic Black children were less likely to undergo definitive imaging, meaning like an ultrasound, a CAT scan, and MRI. Those are what we typically use to diagnose appendicitis during that preceding visit. So these data suggest that disparities in diagnostic imaging may lead to delays in appendicitis diagnosis, and thus may be contributing to the higher perforation rates that are demonstrated in non-Hispanic Black children. So just as we had documented inequities in pain management for children with appendicitis, we've also investigated whether such trends exist in the management of pain for children with long bone fractures. And I want to share this study as an illustration of why, when we're conducting equity-related research, it's important to take a nuanced approach and why patient-centered outcomes matter. So in this study, compared to non-Hispanic white children, non-Hispanic Black and Hispanic children actually had higher odds of receiving any analgesia. So if we'd stopped here with our study, we may even be giving ourselves a pat on the back and saying we're actually managing pain in children of color better than white patients. But if we look more closely at the types of analgesics children were receiving, we discovered that Black and Hispanic children had lower odds of receiving opioid analgesia compared to white children, even after severity adjustment. But perhaps it doesn't matter whether or not there's differences in the types of pain medications used, as long as patients are achieving reductions in pain. So let's look at clinical outcomes. When we looked at whether or not there were racial and ethnic differences in achieving at least a 2-point reduction in pain score, which is based on a 10-point scale, we found that Black and Hispanic children actually had higher odds of pain reduction from highest pain score. So we're good, right? But then we looked at the likelihood of moving into mild or no pain categories. And we found that Black and Hispanic children were less likely to have optimal pain reduction. So, we've seen data that reveal racial and ethnic disparities in the healthcare provision of children, but what are the causes of these disparities? And so some of our current work now includes understanding the sources of healthcare disparities, and then of course, developing interventions to target them. So this is a conceptual framework by Kilborn and colleagues that I like to use, and it highlights the potential causes leading to healthcare disparities and includes healthcare system factors, patient level factors, provider level factors, and then of course the clinical encounter. A lot of the work that our team is pursuing is focused on healthcare system factors, provider level factors, and the clinical encounter. And I'll be speaking with you a little bit more about that as we move along. So, I want to talk about the clinical encounter and how that can be prone to inequities. The National Survey of Children's Health was a telephone survey of over 100,000 households around the country. And the authors in this study noted that in comparison to white patients, minoritized patients rated lower levels of satisfaction with respect to enough time spent with the clinician and provider communication. So, so now I'd like to spend a little bit of time talking about bias. Our team is very interested in studying the impact of bias on healthcare delivery. And when we talk about bias, there's two types of bias, explicit and implicit. Explicit bias reflects our attitudes or beliefs on a conscious level. And this is in contrast to implicit bias, which refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So here's an example of explicit bias. This was a study that was conducted by researchers out at UVA, and they examined whether racial bias was related to false beliefs about biological differences between Blacks and whites. And what they did was they surveyed white lay people through an online survey. And then they surveyed medical students and residents at University of Virginia. And although you can see that medical trainees were less likely to endorse these false beliefs, almost 10% believed that Black people's nerve endings are less sensitive than white people's, and that Black people's skin is thicker. And that almost actually over a third believe that Black people's skin is thicker than white people's. So remember that these are medical students and residents who are now attending physicians out in the world, treating patients and teaching our future healthcare clinicians. So this is just one example that demonstrates that we as healthcare providers are not immune to bias. And then I'm sure many of you are familiar with the implicit association test, which is a tool that measures implicit bias. There's many types of implicit association tests, one of which is race, and that measures differences in preferences between white and Black faces. So just for a quick review, the IAT or the implicit association test is a computer-based measure that requires users to rapidly categorize two target concepts with an attribute. So for example, Black and white with good and bad. And the scoring incorporates correct pairings as well as response latency. It's a validated measure and cannot be faked. So do physicians have implicit bias? Investigators asked over 2,500 physicians to take the IAT, and they also answered a questionnaire to measure explicit bias. And scores range from -2 to +2, with 0 indicating no bias. negative scores indicating a preference towards Black, positive score indicating a preference towards whites. And as you can see, physicians overall had a moderate implicit and explicit preference for whites over Blacks. And then here, the mean implicit and explicit bias scores by race and ethnicity and gender of the physician who was completing the test. And based on this study, white male physicians showed the largest implicit preference for whites, and Black females showed no implicit bias towards Blacks or whites. So, I just showed you some data that we all have biases as clinicians, but does that affect the care that we provide? So investigators asked over 100 clinicians to complete the IAT, and then they administered a telephone survey to almost 3,000 patients stratified by race and ethnicity, and asked them to complete a survey addressing components of patient-centered care. They then compared patients' perception of care by clinician IAT scores. And interestingly, the authors found that as clinicians showed higher implicit preferences for white patients, Black patients rated clinicians lower with respect to interpersonal treatment, communication, trust, and contextual knowledge. So perhaps Black and Hispanic patients are perceiving lower quality of care based on our implicit bias, but do our biases really affect the care that we're providing? As of currently, there have been no studies that I'm aware of that have actually studied actual care provision based on implicit bias. But there have been a few studies that have evaluated care through simulated cases. And so this study provides one such example. In this study, the investigators evaluated whether implicit bias predicts opioid prescription by pediatricians based on a clinical vignette of a 14-year-old male who was being discharged home after reduction of a femur fracture. So in this study, the authors found that pediatricians with greater pro-white bias were more likely to agree with prescribing opioids to white patients, but more likely to disagree with prescribing it for Black patients. And then, as we all know, working in the hospital setting can be very stressful. Working in the emergency department, some may argue, could be even more stressful. So a prior study investigated whether bias is increased after an emergency department shift and whether it's more pronounced when you're carrying a higher patient load. So this was a repeated measure study of residents in a pediatric emergency department in which they completed the implicit association test, both pre and post emergency department shift. And what they found in this study was that the majority of pediatric residents enrolled had a pro-white anti-Black bias, both pre and post emergency department shift. But interestingly, they also found that pro-white anti-Black bias increased post emergency department shift among physicians who were working during high emergency department volumes or when they were carrying a large patient load, suggesting that when we get stressed, not surprisingly, our biases may be more pronounced. So as of recent, there's been tremendous amount of time spent towards documenting disparities. More work is now being done to understand the contributors to such inequities. And what we, as equity scientists, need to start focusing on is developing evidence-informed interventions to mitigate inequities. So I want to spend a few minutes discussing some important steps when we're designing such interventions. When we're developing interventions to mitigate disparities, we want to make sure that we're identifying outcomes that are patient-centric. And what I mean by this is, will these outcomes be meaningful to the patients and the families we're caring for? And so this is really best achieved through community input. I can't emphasize enough how important it is to include patient perspectives when we're undertaking initiatives, whether they be research, quality improvement, or implementation of new care delivery. And then we also want to identify outcomes that are clinically relevant and meaningful. And we also want to make sure that our interventions are cutting across all aspects of clinical care. So, for example, if we're trying to mitigate inequities in managing pain, but our intervention focuses strictly on clinician response to certain pain scores, but isn't incorporating nursing documentation of pain scores, our intervention may not be successful. And then as racial and ethnic disparities in care are being recognized, and we're developing interventions to help mitigate these such inequities, it's important to be targeting different sources of the disparities that we've discussed. So, some interventions will target patients through education, others target providers. And so these interventions have studied the implementation of clinical practice guidelines, provider audit and feedback, provision of computerized decision support. Others target healthcare organizations and develop community level interventions through deployment of case managers and community health workers. And then the interventions that have shown the most promise are those that are multi-targeted, incorporating multiple levels. So this brings me to the objectives of our currently funded study through the HEAL initiative. Our study is titled PAINT, Project Addressing Inequities in the Emergency Department. And in these studies, we plan to develop interventions that will mitigate inequities in pain management when children are presenting to the emergency department and are diagnosed with appendicitis and long bone fractures. So in the first part of our study, we have two aims. Aim one of our studies seeks to measure how clinician, including both physicians and nursing, implicit bias is associated with quality of care for pain management. And so, you know, we're seeking to really understand one of the potential factors that are associated with healthcare inequities, the role of clinician bias. And we seek to understand the impact of clinician bias, not just on patient outcomes with respect to pain management, but also patient experience with respect to clinician communication, respect, and building trust. And so to achieve this aim, we're asking clinicians to complete a survey that includes items related to their demographics, explicit bias, as well as complete the implicit association test. And so we're asking both nurses and physicians in our emergency department to complete this questionnaire. And then we're also administering surveys to patients who are presenting to the emergency department with abdominal pain or injuries. And you know, these surveys include like their assessments of their experience using validated surveys, assessing clinician communication, trust, respect. And then we're going to be linking clinician IHE scores to both electronic health record data, as well as those patient-reported experience data to measure the impact of implicit bias on real patient outcomes and experience. And then concurrently, we're developing quality metrics that are patient-centric. And many of the quality metrics that we currently use in healthcare were developed by those who are not on the front lines delivering clinical care and have not been patient-informed. And so we are planning to use a community-engaged approach of patients, caregivers, nurses, physicians, child life specialists, pharmacists, information technologists to develop patient-centered quality metrics. And then these metrics will then inform the development of equity report cards and electronic health record embedded clinical decision support tools that will be designed to improve equity and care delivery. So then in the second phase of the award, we will be measuring the impact of two interventions. One, the provision of equity report cards, and two, EHR embedded clinical decision support on mitigation of inequities in pain management and patient experience, again, among youth that are diagnosed with appendicitis and long bone fractures. And so these equity report cards will be provided on a monthly basis and will be providing an evaluation of assessment and management of pain, as well as data from the patient surveys, evaluating the patient experience. And then the clinical decision support tools will be role specific, meaning specific to nursing tasks and physician tasks, and will provide real-time decision support on pain management. So for example, for nursing, it might have a reminder to reassess pain, whereas for a physician, it might provide a reminder to address pain in a patient based on their pain score. And then we're going to be conducting an interrupted time series analysis to evaluate the impact of these interventions, both independently, but then also in synergy. So at time one, only report cards will only be administered to the physician staff. At time two, we're going to be providing report cards to both physicians and nurses. At time three, we're going to add the clinical decision support tool to just the physicians. And then at time four, we're going to be providing the report cards and the clinical decision support to all. So in conclusion, racial and ethnic inequities in pain management are prevalent. There's multiple structural, institutional, and individual sources of bias and racism, and evidence-based interventions to mitigate inequities are lacking. The PAIN study will address these gaps in an effort to mitigate racial and ethnic inequities in pain management among children. And with that, I'd like to thank you for your time, and I'd be happy to answer any questions.
Thank you so much, Monica. Some sobering data there. I'd ask people to put their questions in the Q&A. We're going to get to those after our next talk. Monica, are you able to stay? Yeah. Okay. Great. Our next presentation is by Dr. Gail D'Onofrio. Gail's the professor of emergency medicine and professor of medicine at Yale School of Medicine. She's board in emergency medicine and addiction medicine. And she has been working for a long time in this problem of opioid overuse and management of people with opioid overuse in emergency departments. Gail, looking forward to your presentation.
Thank you. Let's just make sure I can find it for 1 second. Of course, it's not on here. A second, here we go. Okay, can you see that fine?
Yes.
Looks
Okay.
good.
Thank you. All right, here we go. Thank you so much, and I appreciate the time to talk about ED-initiated buprenorphine for opiate use disorder. I have no disclosures, although I am funded by the following sources. So just to start out so that we're all on the same wavelength, and I think most of you probably know this, but we all know the extent of the problem. There are over 9 million people in the US who over the age of 12 who report misuse of opiates, and 5.6 million that have an opiate use disorder in the past year. We know that overdoses continue to rise each year, and those are primarily driven by fentanyl. And unfortunately, we've learned recently that our adolescent population is extremely at risk, and our overdose mortality has increased 94% since the last year. So, I mean, it's 94%, and that's a 20% increase from the last year. So we also know that the treatment gap remains very large. And recently, a recent article that just came out wondering whether the treatment gap did narrow with increasing in medications for opiate use disorder. We found that even though we have increased our use of these medications over the past year, that only 13.4% of individuals with opiate use disorder do receive these life-saving medications. We also know that the ED offers 24/7, 365 option to help combat the opiate crisis. And why do we focus on that? We've heard from Dr. Goya, because that is where the patients are, and this is where people have access to care 24/7. We also know, unfortunately, what the consequences of inaction are. And I always talk about this article from Dr. La Rochelle from Boston Medical Center, because it's so important to see what had been going on. Massachusetts is able to link lots of databases with, as you see, over almost 18,000 patients. These were individuals who actually suffered a non-fatal overdose and were seen in emergency departments. If you looked at what happened to them over the next 12 months, we found that less than a third of them actually received medications for opiate use disorder, and that the all-cause mortality was approaching 5%. Why that is important is there's really nothing else that approaches that except an ST elevation myocardial infarction. We also saw that if they did receive opiate agonists, and particularly if they received those, buprenorphine and methadone maintenance, they decreased their mortality for over 50%. Those that received no treatment or naltrexone did not have any reduction in mortality. So we also know the evidence in the emergency department, and this was a paper that we at Yale had come out with in 2015. This was really an efficacy study in that patients in the ED were administered buprenorphine, particularly enrolled that were 18 years and older by myself, and they were treated with Dr. Filene in a office-based treatment program. and they received the medication with them as they went home. So everything happened exactly the way we would hope it to be. We really were not expecting the results to be as striking as they were, but almost 80% of people who received the buprenorphine did follow up and were still engaged in active treatment at 30 days compared to those that received a brief intervention or just referral. Those are probably higher than the normal groups that would occur in other EDs, and that because in our institution, that's what we have been doing for long periods of time. We also found that their 7-day illicit opiate use decreased, and we also found that this was quite cost effective. So what did we learn from all this? We learned that doing that efficacy study was relatively easy compared to translating research into practice, that implementation is not so easy and is quite difficult. We were lucky to be funded by the CTN on what was called Project ED Health. And this was a very large project that took place in Baltimore, in New York City, in Cincinnati, and in Seattle, Washington, with a large group of individuals who helped out. This paper was just actually published this week. It was called in JAMA Open Implementation Facilitation to promote ED-initiated bupe for opiate use disorder. This was a hybrid type 3 effectiveness implementation trial, which meant we were really focusing on implementation. What we did was we went to all these 4 sites, and the initial intervention was myself. I went and gave your classic 60-minute grand rounds where people could ask me questions. I stayed for as long as people wanted. I visited and talked to a lot of individuals, as one would do with a visiting professor in grand rounds. We then looked for 12 months, and we looked at 2 different things. We looked at clinician use of buprenorphine, as well as we enrolled patient cohorts during specific enrolling shifts of individuals who were over 18 who were not engaged in opiate use treatment. And we just talked to them, and we looked at whether they were engaged in treatment, whether they were administered buprenorphine and naloxone in the ED, and whether or not at 30 days they were in treatment. We then had a 6 months, very intense implementation facilitation time where we did surveys and focus groups in each of those sites. And that whole bundle of activities that we did were feed monitoring and feedback, and did learning collaboratives, et cetera. And then we repeated our 12 months of observation, whether that was through the EHR data or enrolling another group of patients at each site. So what did we find? First of all, in terms of overall implementation that we derived directly from the EHR, we found that in all sites, you can see we had a 6-fold increase in ED visits where buprenorphine was administered or prescribed during that period. And in each site, we did see an increase in clinicians administering ED-initiated bupe. Even in those sites, as you can see, B and C, that had not done it at all at baseline, were now doing it. And more importantly, there were lots more unique, 3 times more unique ED clinicians administering or prescribing bupe than had been in the initial cohort. In terms of patient outcomes in our cohort, we had 364 patients in our first 900 or so, almost 400 in the first cohort, and 360 in our post 12-month cohort, primarily limited by COVID hit just sort of at the end. And what we did find is that in terms of implementation, there were very few. There were only 2 patients in that first cohort that actually received buprenorphine while they were in the ED. And in the second cohort, that went to 53 or 14.6%. So a modest increase, but nevertheless, a major increase from over the 0.5. When we looked at the percent of patients who were engaged in formal opiate use disorder treatment on day 30, we also found that we went from 10 to 16% in the evaluation period. So we looked very carefully at this group that received treatment and went on to be engaged in treatment at 30 days. And what do these individuals look like? So now if you look at this, we found that during the baseline period, there were 40 patients who were engaged in treatment, one of which who had received bupe. And when we got to the evaluation period after IF, we found that at this point, there were additional people, so 59, but 19 of those, that real difference was really as a result of patients who had received bupe. So if you look at those who in the IF period received any bupe or did not receive bupe, you can see that there's a marked difference in that if you did receive bupe, you were 36% of those went on to treatment. So although these were modest results at the end, they were clearly showed that buprenorphine was of great help to our patients. So what did we think of that? We thought, well, one of the things you can see from that group is that obviously when I went to give the talk, that nothing really happened. And that was really demoralizing from a step there, but that we needed to do many of the things that we had done in implementation facilitation. And even though that was a large, very, very large trial and had somewhat modest results, we learned a lot from that. And one of the things also that we were studying at the same time was embedding a clinical support system into an EHR. So I did with Dr. Melnick, and this was a really pretty aggressive NIDA-funded trial where we used 18 emergency department clusters across 5 healthcare systems in 5 states. And these ranged anywhere from community hospitals to tertiary care hospitals. And we used the platform of either Epic or Cerner electronic health records. And then patients who received the intervention had this very physician-facing clinical decision support system that was integrated into their workflow. We looked at both whether the individual patient received more ED-bupe and whether there were more physicians who were doing that. And what this study did add is that we were not able to see a difference in that study on the prescribing at the patient level, but we did find that actually those individuals, those clinicians were actually prescribing bupe at a much better and larger rate. As you can see here, 44% in the intervention arm compared to 34% in the usual care arm. So what we can see here is that not only do we have to have education, we have clinical support, but there are many other things that will help us put this piece of puzzle together to increase MOUD. But what did come out of all of those is that Epic has now actually literally embedded our clinical pathway into their new version of Epic, and anyone who has Epic can download it. We also developed certain apps such as bupe initiation that anyone can get from any smartphone. It's free, and that here are some screenshots from it, very, very quick, that anyone can look at. You can tell whether the person has opiate use disorder by opening up the DSM-5 questionnaire, and it will actually score it for you. It will actually do the clinical opiate withdrawal scale. If you enter in the items, it will give you the score. And if you need some patient needs some motivational readiness, it'll tell you how to go about doing that. So we continue to test new ideas. And so this brings us to our current funded HEAL study, which is ED innovation. And this is a type 1 effectiveness implementation design we started with that actually is emphasizing, again, effectiveness over implementation. Though we did implement ED-initiated bupe in 30 sites, diverse sites around the country. And then we were particularly looking at the effectiveness of 2 preparations of ED bupe. One is XR bupe, which is this extended release buprenorphine, CAM38, which is by Braemer, and that is still under IND at this point and may come to market in the next few months, versus our traditional sublingual bupe inductions, and approximately 2,000 patients with untreated opiate use disorder in the ED, and the primary outcome being engagement in formal addiction treatment at 7 days. So patients are 18 years or older. They have a CAL score of greater or equal to 4, and they have to be able to speak English in this study, which is unfortunate, but it's very difficult to do without entire staff in Spanish. We exclude patients who have methadone in their urine, are pregnant, that require hospitalization, or that have been enrolled in a treatment program receiving MUD anywhere within the past 14 days. So just to teach you a little bit or learn a little bit about CAM 2038 is the pharmacokinetics of both of these. And again, the pharmacokinetics of sublingual is very well known. If you take it, you're going to have a rapid rise in plasma concentration that really deprecates over a period of time. very short period of time, usually a day or so. So then when you look at XR-bup, it is a gradual rise. We get to about 2 nanograms per milliliter at 4 hours. And then this rise continues and it stays for approximately 7 days. We are using the 24 milligram, which is consistent or with 16 milligrams of buprenorphine per day. A very large team and could not be doing this without this whole team, as well as all the ED Innovation Core investigators throughout the US, which is quite a substantial amount of people. We started with 28 sites and 27 institutions, and we are currently enrolling in 18 sites and 17. Those were because either individuals could not retain some of their staffing, or they were not able to consistently enroll. We had lots of issues as we went through this period of COVID, et cetera. We're doing quite well now, though, and we are currently at 1,460 patients. So we're 63% of our goal. We're hoping to finish this calendar year and to get some of our results out there. So what I can tell you about the patients that we are seeing, though, is that there are 68% male and 32% female. It is a fairly diverse group of individuals in that we have 31% identifying as Black or African American and 14% as Hispanic or Latino. As we look at all the different types of things that social determinants of health and things that we worry about that would make people less likely to be able to have great outcomes, you can see that our population is quite vulnerable. There are only 22% who are currently employed. And what we are seeing more and more across the US, which is making everything much more complicated, is that half of our patients have had unstable housing in the last 12 months. And currently 35% are in an unstable housing situation. If you look below there on the urine drug screens, many patients have tested positive. These are point of care testing for fentanyl. There's about 3/4 who have been using fentanyl, lots of amphetamine and methamphetamine, and cocaine. We've seen much more variations regionally in that amphetamine, methamphetamines are much more on the west, cocaine is much more on the east. And we even have a fairly large group, 38%, who have tested buprenorphine in their urine. It means that these individuals are trying buprenorphine on their own illicitly. So I'm excited to share this paper that came out last week on March 30th, and it was on our incidence of precipitated withdrawal during this multi-site trial. And this is a very exciting trial for us because it is literally the first trial that used uniform surveillance, operational definitions, and adjudicated outcomes and documented buprenorphine-induced precipitated withdrawal in persons using fentanyl or non-using fentanyl. And this was how we were able to do this in the light of our ongoing trial, and it was very prospective. In the past, there have been anecdotal reports or case series that have documented patients, but no normal denominators of how many of those patients who did have precipitated withdrawal, where were they coming from? So this was really important. What we found, though, that was buprenorphine induction remained safe and effective even when fentanyl was present. And here are all of our sites. The black circles are the sites that are enrolling. These are all 20. These came from all 28 sites. And you can see in the stars are the places where we had precipitated withdrawal. There were 5 sites in the pinkish purple that was an individual used sublingual bup. And then there were 4 sites in yellow where the XR-bup precipitated withdrawal. And those were, as you can see in the bottom, pretty much around the country. This was reported at 1,200 patients, but I will tell you, as we had 1,460 plus as of today, we still have not had any more cases of precipitated withdrawal. All 9 of those cases did have fentanyl in their urine. All but 1 had other things in their urine as well. And there was really nothing that I could tell you that was different about these individuals at all compared to the entire set. of patients who are enrolled, and all of them, though, were discharged from the hospital, from the emergency department. One of them left against medical advice. The other 8 stayed for a few hours up till observation overnight. So again, many of these individuals are homeless, and they were able all to leave without being admitted. So our precipitated withdrawal rate was quite low, as you can see here, less than 1%. So what do we need to investigate, and what are our strategies going forward? We're excited to finish this trial. Hopefully, we do have a supplement, Dr. Coupe, that will be looking at disparities and whether there are any racial ethnic differences or anything in our outcomes, and is actually doing some qualitative analysis and in interviewing many of our patients in all racial and ethnic groups. So we'll be excited to see that. We also are looking forward to looking at different dosing and formulations because this is very important. Are there certain dosing strategies that may have individuals do better and engage in treatment? What continue our drug surveillance, which actually we are looking at in all these emergency departments, what drugs individuals are using. We're also storing their urine. So later we'll be able to look at some analogs and xylazine and other interesting things that may be occurring in their urine that may have something to do with the local geographic area. We hope we also we're going to be thinking about adolescent treatment and harm reduction. That's a really important area. And also pre-hospital treatment. Can we expand some buprenorphine in the pre-hospital setting? So if individuals do not want to be transported, is that a potential thing? So all of these things will kind of add to what we know really already. And then, of course, there are many strategies. We need to not only integrate clinician support, but it needs to be tailored to individual sites. And clearly these things need to go together. We have to do education. We have to have some type of quality improvement. And that's really important. We need to leverage that improvement frameworks and modern feedback that have real rewards and consequences. We know that door-to-balloon times really decreased, and all of us who are emergency physicians get tons of EKGs thrown in our face every 5 minutes when we're in the emergency department. And we know exactly what to do, and we are held accountable if we don't. So we need to keep that level of vigilance for individuals who have quite substantial risk of death to do with opiate use disorder. We also are working towards trying to revise regulation and allow hospitals to dispense buprenorphine at the time of the ED visit. This is done sometimes by SAMHSA and other funds, state funds that are given to hospitals, but we need to be able to access insurance types and really promote access to make this sustainable and make sure access is available, because we're finding out that many individuals can't even fill their prescriptions because of this suspicious order reported system that often bars pharmacists from giving out larger amounts that we might prescribe up to 1 or 2 months in some individuals. And we need to promote this legislation of quality measures, and that will help require navigators, social worker, recovery coach, whatever it is that we see, and we're still testing, that should be included. We know that they need to be included in ED staff and really held accountable, and there should be fidelity to their interventions. So we have a lot going on, and we're really excited to the HEAL initiative for funding us and continuing to fund us. And I will take any questions. There are websites that are available for anything that you would like to know about, whether there are papers or different types of home and or on your own induction strategies that are available to you. And I appreciate your time. Thank you. I'll stop sharing.
Thank you so much. Why don't we go to some questions now? Ziwi Nataba asked Dr. Goyle if you could talk about, can you say more about the core elements or strategies to mitigate health inequities, i.e. community engagement, clinical guidelines, support tools, and so forth? You talked about report cards, and any other things to put out?
I think for each of those, you could spend days talking about each of those in terms of what are the core elements. I think, the most important thing is to think, everything really, we really need to think of it. And Dr. Donferrio also said this, like you need to have a user-centered design, right? Whenever you're designing something. And so the way to do that is to engage your community partners who are going to be engaging with whichever intervention that is being designed. And so I think that's where the community engagement piece is really important. And when I say community engagement, that's not just, that includes not only the clinicians, but also the patients. And for us in the emergency department, oftentimes we just think about the parents, but we've tried to be really intentional about including patients, children, and the youth that we're developing these interventions for, to be really involved in every step of the work that we're doing. So I don't know if I'm able to answer your question with enough detail, because I think it just, again, each of those components could be a talk in and of itself, but at least having that, having the community kind of at the heart of everything that you're designing is really important. I can't emphasize that enough.
Thank you very much. Let me ask Gail, in terms of the precipitated withdrawal, I was unclear a little bit about the timing from last use to when you start the buprenorphine. And actually, well, yeah, anything to say about that?
Sure. So in light, we're doing it again in terms of the trial of ED innovation, and anyone can be enrolled in the trial that has an opiate withdrawal scale of 4 or greater. If the person is randomized to the sublingual arm, those individuals, if they have COW scores that are less than 8, so we'll say between 4 and 7, they are given induction strategies to do on their own. So I said we don't use home anymore because so many of these individuals don't have a home. So they are given very tight instructions of how to initiate that on their own. The question could come up, or are we missing those? Well, we have an 86% rate of finding patients at 7 days. And so we would not be missing them because we tell them to come right back and we're talking to them all at 7 days. So we don't feel that that's the case. If they are there and their scores are over 8, they receive 8 milligrams while they are there in the emergency department, and everyone's discharged with 16 milligrams a day. If they are randomized to the XR group, they are able to get the injection at 4. And so we have had no, as you said, only had 4 of those individuals who went into precipitated withdrawal who have received the injection. So we're really quite excited about this. What I will say, these are ED patients, so we are there all the time. If people do not feel well, if they tell us that they don't feel well even, or whatever, or their scores go up a little bit, we're fairly aggressive in rescuing with more buprenorphine, etc. So this may not be the case if you're just dispensing it outside and the patient leaves. So people leave when they feel better. The observation course is at least 2 hours, but they are there till they feel improved and they go home. But each of those cases, precipitated withdrawal is pretty obvious when you see it, and they're all cases were adjudicated. So we feel pretty strongly that we have not missed anyone, and we've been able to do this. And it's important that everyone understand that, because I think people are so worried about using buprenorphine. Remember, that's like half of the best medications we have. So we need to make sure people are using it correctly.
Okay, thanks very much. Dr. Gail, another question, maybe in the weeds a little bit. In terms of your study, they were assuming that the providers would have to opt in to the study, and would that then lead to some kind of sample bias in terms of the people who want to join, or people who want to do better, and the people we're really trying to help, they don't want to join your study?
I mean, absolutely, right? So this is, we've done some education around what the IET means. You can imagine that there might be some sensitivity around that, right? I think the last thing anyone wants is to be labeled a racist based on their IET scores, and then there's the potential for fear of like, what's, you know, who's going to be sharing, who's going to know this data? Like, who's going to know this about me? And how are they going to judge me based on that? And so, you know, we've tried to take multiple steps. So it is opt-in. I mean, we can't force anyone to take it. We did a lot of education around what it means and how the data is being shared. So the way that we have, the way that we've structured this is that nobody from the study team or any of the physician leaders will be able to link a physician or nurse's IET score with that individual. And so there's no way that I can find out, you know, what people's link their IET scores to their names. And then we did some surveys with our clinicians to ask, you know, would they be willing to do this, and pre getting funded. And you know, majority, I would say, I think it ended up being like 94% said they would. Now, saying you're going to do something and doing something are two different things, right? So, you know, we just launched the IET survey on Monday, so we will see. But so far, the uptake has been pretty good, and so we're optimistic. But it's definitely something that we, you know, that is a concern, and then we'll be doing some sensitivity analyses, you know, when it comes down to analyzing the results of this work.
Very much enjoyed hearing from both of you, and I'm sure we could talk for hours and hours about this, and maybe someday we will. But I think we have to close right now. And again, thanks so much for your time and for your work.
Thank you.
Thank you.
All right, bye now.